Hello friends, let us come to the last topic of this unit, the unit of nose and paranasal sinuses. The topic is CSF rhinorrhea. Okay, but last but not the least, this topic has a lot of MCQs which are frequently asked in the exam. We'll get to know them as we go through this topic. So let us start with the CSF rhinorrhea. First, a quick recap about the CSF flow. Now, where is this CSF produced? This CSF is produced by the choroid plexus in the lateral ventricles. Alright, and from the lateral ventricles, it comes through the foramen of Monro into the third ventricle. Right, and from the third ventricle, we know it goes through the aqueduct of Sylvius into the fourth ventricle. Right, now from the fourth ventricle, this crosses the foramen of Luschka and Magente. Right, and it goes into the subarachnoid space, which is over the brain and the spinal cord. Right, so this is the flow. Now, where is this CSF absorbed? So now you see this CSF is reabsorbed in this subarachnoid space by these arachnoid granulations. Okay, so these arachnoid villi, they absorb this CSF back into the venous sinus blood. Okay, so this is how the CSF flows. Right, now let's come to CSF rhinorrhea. CSF rhinorrhea, a patient is having the CSF which is coming from the nose. How will the patient present? Patient presents with clear watery discharge. The patient will give you complaint of clear watery discharge from nose. Right? Okay. So remember, I have used the word clear watery. If you listen to me carefully, this word watery I am using for the first time in the whole nose and paranasal sinuses unit. Because whenever the word watery is given to you in the exam, you must think about CSF. Okay, otherwise the nasal discharges are all mucoid discharge. But the word watery we have reserved for CSF. So clear watery discharge. Now this discharge increases on coughing, straining, sneezing, bending forwards. Right? So coughing, straining, sneezing, bending forwards, all of this leads to increase in the CSF pressure, and therefore more CSF will come out. Patient has CSF rhinorrhea. Alright, now question is why it will increase on bending forwards. You see, bending forwards, you see, when a patient is in lying down position or patient is sitting position, this CSF goes and collects inside the paranasal sinuses. So when the patient bends forward, just like a kettle, just like you see a kettle, when you have to take the tea out of this kettle, you have to bend it forward. So similarly, when you bend the face forward, the CSF will come out of the sinuses and it will present as CSF rhinorrhea. So this is known as reservoir sign or teapot sign. Okay, so that means the paranasal sinuses, they are acting as a reservoir. So when the patient gets up after lying down for some time, when the patient gets up, okay, the CSF comes out. So that's known as reservoir. They're acting like a reservoir. Patient bends forward like a teapot and the CSF comes out. So it is known as teapot sign. Okay. Remember, I've also told you reservoir sign in case of mastocytitis in the ear. So that was the reservoir sign of ear. Okay. And this is the reservoir sign in CSF. So this is in the nose, that was in the ear. There are two reservoir signs in ENT, one for ear that was seen in mastocytitis, and this is the reservoir sign in the nose that is seen in CSF rhinorrhea. Right? Okay, don't get confused. There are two reservoir signs in ENT. Alright, next, how can we differentiate this CSF from nasal secretions? So remember, from the nose we can have nasal mucosal secretions. How will we differentiate? How can we say that this is CSF and not nasal secretion? So you see, number one, patient gives a history of some surgery, or there is some head injury, or there is some intracranial tumor, something like that. There must be some history, right? Okay, sometimes there may not be any history, but usually patient comes with this history. Whereas in case of nasal secretions, patient will give you a history of there is a sneezing, nasal obstruction, there is itching in the nose, excessive lacrimation, conjunctivitis, allergy symptoms. So all these will be present in case of nasal secretions. Okay. Now, character of discharge. As I just told you, CSF is clear watery discharge, whereas nasal secretion is a mucoid discharge. Okay. So remember I told you the word watery we have reserved for CSF over here. Okay. Next is the flow of discharge. Now you see the CSF discharge, as discussed earlier, it increases on coughing, sneezing, straining, bending forwards. What about nasal secretion? It is a continuous secretion. Okay, right? It does not increases with coughing or straining. So it is there, it is there. Next we have the sniff test. So what do we do in the sniff test? You ask the patient to sniff back the discharge. Now he cannot sniff back the CSF. So the test is negative, whereas he can sniff back the nasal secretions. So that's a mucoid discharge. You can sniff it back. CSF cannot be sniffed back. Right? Now you can also do a test that is known as handkerchief test. Now what is done in handkerchief test? Remember the nasal secretions, they will stiffen the handkerchief, whereas the CSF does not stiffen the handkerchief. It will not make it stiff. So we can also do a test known as handkerchief test. Now once again the handkerchief test is negative in CSF because it will not stiffen it up, whereas the nasal secretions will stiffen up the handkerchief. Okay. Next, to confirm, we can do a glucose test. Now remember the glucose is present in CSF. How much glucose is present? Approximately 40 to 60 milligram per deciliter. Right? So remember CSF blood sugar levels, if you compare with that, it will be 2/3. So CSF sugar is 2/3 of the blood sugar levels. Right? So blood sugar levels is generally 60 to 90 milligram per deciliter. So CSF is 40 to 60. Nasal secretions, the glucose test is negative. Okay. We have less than 10 or 5 milligram sugar in nasal secretion. So it is almost negligible. The test will of course come as negative. Now if you are still having any doubt, you can do a test known as beta-2 transferrin test. This beta-2 transferrin protein is found only in CSF. It is not found anywhere else. Okay. So remember the beta-2 transferrin, this is found only in CSF. So this is a gold standard test for CSF. Now remember this beta-2 transferrin, it is found only in CSF. So it is specific. So this is the most specific test, or you can say this is the gold standard test to confirm it is CSF. Okay. So the gold standard test for CSF. Right? Okay. Now we have a question over here. This question was asked in the December 2017 in the FMG exam. A male trauma patient. So you see, male is given to us, trauma is given to us, admitted to hospital with watery discharge from nose. You see, history of trauma, watery discharge. So we have our indication on investigation. It showed damage in cribriform plate. What is the possible diagnosis? So answer is CSF rhinorrhoea. Right? Okay. Clear cut question. Answer is CSF rhinorrhoea. Remember CSF rhinorrhoea, most common cause is trauma. Most common cause of CSF rhinorrhoea is trauma. Okay. What kind of trauma? Head injury. Now, if somebody asks you what is the most common site for CSF rhinorrhoea, most common site for CSF rhinorrhoea, so answer is the most common site is fracture of cribriform plate. So remember, cribriform plate of ethmoid, this forms the roof of the nasal cavity, and this is the thinnest bone in the body. So fracture of this cribriform plate is the most common site for CSF rhinorrhea. Okay, let's go to the next question. CSF otorrhea is due to involvement or trauma of. Okay, now you see, when this question is given in the exam, 90% of students make the mistake and they mark the first answer, cribriform plate of ethmoid, which is a wrong answer. Look carefully, this is otorrhea. Yes, that's why I have put this question over here, because this is otorrhea. Otorrhea means coming from the ear. Okay, so this question was asked in the FMG June 2018 exam, and the answer to this is fracture of petrous temporal bone. Okay, don't get confused. Look carefully over here, CSF otorrhea. All right. Now remember, fracture of the petrous part of temporal bone, it can cause both otorrhea as well as rhinorrhea. Now, how can it cause rhinorrhea? You see the CSF which comes into the middle ear. Now, from the middle ear, it can go through the eustachian tube into the nasopharynx, and from the nasopharynx, it can come into the nose and present as rhinorrhea. So, petrous temporal bone fracture can cause both otorrhea as well as rhinorrhea. Now, such a type of rhinorrhea, which is because of fracture in the ear bone, temporal bone. So, there is no problem in the nose. The CSF is coming from nose, but there is no problem in the nose. The problem is in the ear. This is known as paradoxical CSF rhinorrhea. Okay, known as paradoxical CSF rhinorrhea. All right, now let's say this CSF is mixed with blood. This CSF is mixed with blood. Can you do the sniff test? No. Why? Because you cannot sniff back the blood. Can you do the handkerchief test? No. Why? Because the blood will also stiffen the handkerchief. Okay. So, if the CSF is mixed with blood, you cannot differentiate whether this is CSF with blood or it is CSF with nasal secretions. Okay. Can you do the glucose test? No, because the blood has glucose. So, the glucose will always be present. Right. So, you cannot do these tests. How can you confirm? The simple way to confirm is take this drop of secretion, which is CSF. Okay, take this drop which is containing CSF and blood and put it on a blotting paper. What do we see? We see that the CSF diffuses faster. So, CSF, you see, it will form a ring of clear fluid around the blood drop, that is known as halo sign or target sign. Okay, remember what is a halo? Halo is a ring of light, a bright light, and it is generally shown around the angels, gods, deities. So, whenever we see the picture of these gods and angels, you see a halo, a ring of bright light is shown around them. Okay. Now, why is the halo drawn? The halo is drawn because it shows that those are enlightened. Those people, they have reached enlightenment, or they have received special knowledge or special power from above. So, those people have something which they have received from above. They are not just from the earth, something they have got from above, from the sky, from the heaven, something like that. Okay. Similarly, you have a blood drop coming from the nose. Okay, patient has come to you with history of head injury. You are a doctor in the emergency and he is having bleeding from the nose. Some blood drops are there on his clothes. Now, when you look at those blood drops carefully, you see that those blood drops are showing you halo. Okay, so people with halo, blood drop with halo, these are significant. Why? Because they have something mixed from above. So, this drop is coming from the nose, but something has been mixed in it from above. Above means brain. So, what is mixed? CSF. So don't ignore this halo sign on the patient cloth. You will find out that the patient is having CSF rhinorrhea just by having a look at it. Okay, as soon as you have a look at the patient, you see his clothes which are soiled with blood, you will see a halo sign, you know patient has a head injury and patient is having CSF rhinorrhea. So that's a quick on-spot clinical diagnosis, right? Now if you want to confirm it, you can do beta-2 transferrin test. Beta-2 transferrin, as I told you, is found only in CSF. So this is the most specific test or the gold standard test to identify CSF, right? Okay, let's look at this question. Target sign is seen in. So asked in AIIMS November 2017, we know answer is traumatic CSF rhinorrhea. Why not spontaneous? Because it has to have blood. Blood will be seen in trauma. Okay, so traumatic CSF rhinorrhea. Now, let's look at this question. Gold standard investigation for CSF rhinorrhea. Beta-2 transferrin, HRCT, MRI, CT cysternography. I know when you get this question in the exam, oh sir has told gold standard investigation for CSF, answer is beta-2 transferrin. So this is the first choice that you mark, and I'll tell you what, my students, this answer is wrong. Why this answer is wrong? Look at the question carefully. What is the question telling you? The question is telling you gold standard investigation for CSF rhinorrhea. Okay, so let's mark it, CSF rhinorrhea. If I say only CSF, that means you want to identify whether it is CSF or not. So my answer will be beta-2 transferrin. But over here, the examiner has given us a diagnosis, CSF rhinorrhea. He's already telling you what is coming from the nose is CSF. Okay, so you need not confirm that. What do you need to confirm? You need to confirm or find out the site of leak. Okay, when the diagnosis of CSF rhinorrhea is given to you, I tell you find out this patient has CSF or not. It's different. I tell you this is a patient of CSF rhinorrhea. What investigation will you do? If you tell me that sir I'll try to find out it is CSF, that will be a wrong answer, because I am already telling you this is a patient of CSF rhinorrhea. So that you know already. So what do you need to know now? You need to find out the site of leak. Okay, so how will you find out the site of leak? Now we know that the most common cause is trauma, and the trauma means there will be some fracture. We can see the fracture by doing a CT scan. We want to see a fracture of the bone, we can do a CT scan. Which CT scan we can do? We can do a high resolution computed tomography of nose and paranasal sinuses, right? Okay, let's look over here. So this is a CT scan of the nose and paranasal sinuses, high resolution. So we do small cuts, okay, at a very small distance, so that we can be able to see the whole bony structure, and even small fracture can be identified. So what do we see over here? We can see over here in the roof, in the cribriform plate, there is a fracture, and you can see the CSF coming out, right? This is another CT scan where the CSF leak is in the sphenoid sinus. Okay, so remember HRCT is the first radiological investigation that you will do for CSF rhinorrhea. Okay, so that means if a patient of CSF rhinorrhea comes to me, this will be my radiological investigation of choice. Okay, this is my investigation of choice in a patient of CSF rhinorrhea. So is this our answer to this question? No. No, this was not the answer. This is also not the answer. Why? Because I just told you HRCT is the investigation of choice. But I didn't say that this is the gold standard investigation. The question over here asked gold standard investigation. It didn't ask investigation of choice. What is the difference between the two words? You see, gold standard means it should always be able to identify the CSF rhinorrhea. Okay, it should be always be able to identify. So there is nothing better than that. But in case of HRCT, you see what happens. You are able to see the bony fracture, but let's say there are multiple fractures. Okay, there is a big fracture. So what will happen? You cannot pinpoint the site of leak. Why? Because in this you can see only the bone. You cannot see the CSF. So if there are multiple fractures or there is a big fracture, you cannot pinpoint the site of leak for CSF rhinorrhea. So you need to do some other investigation. You cannot see the CSF over here. We want to see the CSF. We can do MRI. Okay. So in MRI, there are two types of images, T1 images and T2. T2, the mnemonic for T2 is World War II. Water appears white in T2. Okay, so water means water, fluid, blood, lymph, CSF, all this will appear white in T2 phase. Right? So we are doing MRI T2 weighted images. We are doing in T2 phase and we can see the CSF. So because we are able to see the CSF, we also call it as MR cysternography. So look in the first image. So this is corresponding to the previous CT scan image where we had a fracture in the cribriform plate, and now you can see the CSF coming out from here. Right? So this can clearly show you that this is the CSF and not some blood clot which is coming out from the brain at this place. Similarly, we had this second picture where there was a leak in the sphenoid sinus. In the CT scan, we saw there is a leak, there is a fracture, and now we can see in the MRI, the CSF is coming out. Right? So we can do an MRI and we can find the site of leak, we can see the CSF. So is this our gold standard investigation? No. Why? Why? We can see the CSF. Because MRI does not show you the bone. Okay? It does not show you the bone, you can see the CSF. So you always have to compare the image with the CT scan image. Suppose as a surgeon I want to operate and I want both the bone and the CSF in the same film, in the same cut. What will I do? I'll ask the radiologist, my radiology friend, to get me some other investigation where I can see both of them together so that there is no confusion. Alright. So for that, what will my radiologist do? He will do a lumbar puncture, and through the lumbar puncture, he'll inject a radiopaque dye. This dye goes into the CSF, right? And then it will come from the nose, and we do a CT scan. We can see both the fracture as well as the CSF. This is known as CT cysternography. So you have a CT cysternogram in front of you. Okay. Now remember, in earlier days, what was done was a cisternal puncture. Okay, because we didn't have very good dyes, so cisternal puncture was done. Okay, so that is why the term cysternography came. But nowadays we do lumbar puncture and we have good dyes which can go up also into the brain and then come out from the nose. But this is an invasive procedure. Okay, even if you are doing a lumbar puncture, it is an invasive procedure. You are injecting dye, that dye can cause an allergic reaction in the brain, patient can even have convulsions. Alright, so it is an invasive investigation. So it is done at the end, when all other investigations have failed to satisfy the radiologist or the operating surgeon. So then we go for CT cysternography. Okay, so it's an invasive investigation, number one, but yes, it shows both bone as well as CSF, so it is taken as the gold standard investigation for CSF rhinorrhea. Okay, now when I say gold standard investigation, I mean the pre-operative investigation, right? So I mean the pre-operative investigation that is used to determine the site of leak. Okay, in this we can see both bone as well as the bony fracture as well as the CSF in this investigation. Okay, so our answer to this question was CT cysternography. Right? Okay, so that is the correct answer for this question. Now remember, I just said that this is the pre-operative gold standard investigation. Do we have something better than this? Yes, we have something better than this also. That is known as fluorescein dye injection. So this fluorescein dye is injected in the operative stage. Suppose despite of all this investigation, in the intraoperative time, the surgeon is confused for the site of leak and is not able to find. So what we can do is we can inject the fluorescein dye through the lumbar puncture, and this fluorescein dye starts coming out from the site for CSF leak, and we can use a blue filter light. So this blue filter light is used, and under the endoscopic vision, okay, you can see the dye coming out under the blue filter light. It shines, okay, it's a fluorescent dye, so it will have a fluorescent illumination under this blue filter, so it will be nicely visible. So this is the best investigation, but this is a operative investigation. Okay, once you are operating under that endoscope vision, you can see this dye. Okay, so best pre-operative investigation or the gold standard pre-operative investigation was CT cysternography. I will not say the word best, I will say the word gold standard. Investigation of choice, I told you, is HRCT. That's the first investigation you will do. Right? Okay, next question is, a 38-year-old patient has presented in casualty after RTA. So, patient had a road traffic accident, RTA, few hours back with CSF rhinorrhoea. So, two things are mentioned to you. This is a CSF rhinorrhoea, it is after road traffic accident. Next line of management is conservative, that means no active surgical intervention, bilateral anterior nasal packing to stop CSF leak, immediate endoscopic repair of skull base, or open neurosurgical repair of skull base. Now, what is the management for CSF rhinorrhoea? This question talks about management. So, we will come to this question. Let us discuss the management of CSF rhinorrhoea. Okay. So, as we discuss, what is the most common type of CSF rhinorrhoea? Answer is traumatic. Okay. We know mostly it is trauma, head injury. Okay. Now, what will you do for this? The treatment is conservative. The treatment for traumatic CSF rhinorrhoea is conservative. Why? You see, there is a bony fracture. What will the bone do after the fracture? It heals. And when it heals, it will stop the CSF leak. Right? So, treatment is conservative. So, what do I mean by conservative treatment? By conservative treatment, I mean, no surgical intervention. So, what will you do for the patient? You will advise the patient absolute bed rest. Okay? You don't want the patient to cough, strain, sneeze, so that the CSF pressure remains low, it does not increases. Okay? For the same purpose, you can give the patient antitussives, cough suppressants. Okay? So, the patient does not cough. You can give the patient stool softeners so that he does not have to strain also. Right? What else can you do for this patient? You can give this patient IV antibiotics. Now, why are we giving antibiotics to this patient? He does not have an infection. These are prophylactic. You don't want him to catch an infection because that will be meningitis. So, you give prophylactic IV antibiotics. Okay. Anything else that you can do? You can give this patient acetazolamide. The normal adult dose is 250 milligram 3 times a day, right? And this will decrease the CSF production. So, you can do these for stopping the CSF. The CSF will stop on its own when the bony fracture will heal. Now, remember over here, you don't do nasal packing. Okay, nasal packing, remember, is contraindicated. Why? Why it is contraindicated? Because it will cause infection. The infection in the nose can go to the brain. Patient can have meningitis. So you never do packing to stop the CSF. However, if a traumatic CSF rhinorrhea patient presents to you and has a lot of bleeding, okay, so you can do packing to stop the bleeding, but not to stop the CSF. Okay, so this nasal packing in CSF rhinorrhea is having a relative contraindication. Okay, you don't do it to stop the CSF, you do it to stop the blood, and then you try to remove it as soon as possible. Right? Okay, the treatment for traumatic CSF rhinorrhea is conservative. Now, how long will you continue this conservative treatment? Okay, we will continue it for 7 days. Minimum we will consider for 7 days. So let's say after 7 days, the CSF does not stop. So now we know that the CSF, if it has not stopped in 7 days, it may not stop at all. Why? Because if the CSF keeps on flowing, it will not allow the bone to heal. Okay, it will make that opening permanent. So you don't want that opening permanent. We know that the bony fracture heals within 2 to 3 weeks times. So you have done this conservative treatment only for 7 days. Okay, the bony fracture has not healed, but the CSF will not allow it to heal. To prevent that, what we will do is, we will do a lumbar puncture. Okay, so that is also a part of conservative treatment. You will do a lumbar puncture and in it you will put a drain. So this is a lumbar drain. Alright, and this lumbar drain, what is the advantage of this lumbar drain? This lumbar drain is connected to a sterile bag. And from this lumbar drain, you will take out CSF. So this CSF starts collecting inside the sterile bag. So slowly, you will drop by drop take out the CSF. So what are you doing? You are decreasing the CSF pressure. You are giving an alternate leak site for the CSF. Right? So that place in the nose where there is a fracture, it is allowed to heal. No CSF flow, it will heal. So how long will you keep this lumbar drain? You will keep it for 2 more weeks. So total 3 weeks have passed. Okay, 3 weeks have passed. In 3 weeks, the CSF has not stopped. Then the bone has healed, the CSF rhinorrhea has become permanent, and then you will have to do the surgery. Okay, the surgery is endoscopic repair. Nowadays, all kinds of CSF rhinorrhea can be repaired endoscopically. So we do a endoscopic repair of the CSF. Right? Okay. Next, look over here in this diagram. What we are doing? We are doing the endoscopic repair. So under this endoscopic vision, right from anterior to the posterior, all kinds of this CSF leak, you can repair under the endoscopic vision. We need not resort to the open neurosurgical procedures for the CSF repair nowadays because of good endoscopic techniques. Okay. So remember, whenever there is a leak, this is repaired in layers, multiple layers. So we use cartilage, we use fascia, we may also use bone. Okay. So multiple layer muscle is used. So multiple repair leak is given so that the leak does not recur once again. Right. So this is the principle of endoscopic repair of CSF. All right. Now, other than this, the CSF rhinorrhea can also be spontaneous. So what do I mean by spontaneous? There is no history of trauma. Now, why can there be a spontaneous CSF rhinorrhea? Okay. Now, there are different theories. The most important is there is a brain tumor. Right? If there is a brain tumor, how can you find out? You have to do a MRI. MRI will show you brain tumor. Or there may be some other cause for increase in intracranial tension, increased ICT. Okay. And once, only when you rule out that there is no ICT, there is no brain tumor, that you will do some surgery. Okay. So what surgery will you do? You will do endoscopic repair. Okay. That is done only after you rule out the intracranial tension. Okay. Now, other than that, we also have paradoxical CSF rhinorrhea. I just told you paradoxical CSF rhinorrhea, the fracture is in the temporal bone. Okay, the CSF is coming from the nose, but the leak is in the ear. Through the middle ear, it comes into the eustachian tube, and from there it comes to nasopharynx and then the nose. So that is known as paradoxical CSF rhinorrhea. Right? Okay. Now, before I finish this topic, there is one more slide. What are the advanced applications of endoscopic sinus surgery? You see, the endoscopic sinus surgery, it evolved to treat the diseases of nose and paranasal sinuses. But nowadays, we have gone beyond the nose. All right? We have gone much ahead of the nose and we treat a lot of diseases. So let's look at what all diseases do we treat other than the nose and the paranasal sinuses. Okay, let's start over here, something that we have already studied. We treat the lacrimal, sac and the duct disorders. So remember, I have told you about the DCR surgeries. Nowadays we do endoscopic DCR. Okay, now we can also treat the orbit. Okay, suppose there is an orbital hematoma. The hematoma is generally behind the eyeball. So it's difficult for an ophthalmologist to go behind the eyeball without damaging it, whereas the medial wall of the orbit can be broken, the lamina papyracea can be broken, and we can straight away go inside the orbit. So orbital hematoma, or it can be an orbital abscess also, easily treated with the endoscope. Okay, nowadays we are even treating retroorbital tumors. So again, these tumors, they present a challenge to ophthalmologists because they don't want to damage the eyeball. So these can be approached easily by the endoscope. Okay, then behind that we have the optic nerve. So optic nerve decompression surgeries are nowadays done by endoscopes. Okay, so they are done by ENT surgeons under the endoscopic vision. Optic nerve decompression surgeries, they are commonly done under the endoscope vision. Right? Okay. Now what else can we do? So that was the lateral. We go up, and up we have the anterior cranial fossa. So with the help of endoscope, you can go inside the anterior cranial fossa and do the surgeries, beyond the cribriform plate. You can do the surgeries for the tumors which are at the floor of the brain in the anterior cranial fossa. Similarly, you can also operate in the middle cranial fossa. Remember, I have told you about sphenoid sinus, and we know that the pituitary gland is just above the sphenoid sinus. So pituitary gland, we have micro or macroadenomas. So pituitary gland as a principle now world over is treated only endoscopically. Alright, so these tumors you can operate under the endoscope vision. You do not damage the brain tissue. You can quickly go and take out the tumor. So they are better done endoscopically than by any open procedure. Okay, question asked in the exam, which part of the brain, which part you cannot reach? Answer is posterior cranial fossa. So remember, with the help of endoscopic sinus surgery, you cannot reach the posterior cranial fossa. Okay, what is there in the posterior cranial fossa? We have the cerebellum. And this question has been asked, you cannot reach the cerebellum because in between you will get the brainstem. So you cannot reach the cerebellum, the posterior cranial fossa, with your endoscope that is inserted through the nose. Okay, remember, you can even reach the vertebra. So this is also a surgery. You can go and you can operate on the C1 and C2 vertebra, commonly done in the C1, C2 fracture. You can go to the nose, directly into the nasopharynx, and just behind that we have the vertebra. So if you go to the vertebra from the outside, you have to go through important vital structures in the neck, and here you can directly reach the vertebra and you can do the nailing, especially in case of a fracture. You can operate on the C1 and C2 vertebra easily with the help of endoscope. But what you cannot do is you cannot reach the cerebellum, the posterior cranial fossa. Okay, so these are the advanced applications of the endoscopic sinus surgeries which we do nowadays. Okay, thank you.